Now let's talk HIV/AIDS, and we're talking about the disease prevalence and how the Ghana AIDS Commission seeks to use its new door-to-door approach to fight the stigma. Here is Mamavi Usabuaje's conversation with the Eastern Regional Technical Support Coordinator, Golda Asante.
The Ghana AIDS Commission in the Eastern region has recently, come out with a new strategy, which is really one that is very interesting. How about a door-to-door service, persons taking care of you or even testing you and having a conversation about HIV and AIDS right at your doorstep. I've got Madam Golda Asante, Regional Technical Coordinator, Eastern Regional Technical Support Unit with the Ghana AIDS Commission, joining me, for a broader conversation for us to appreciate the innovations that they've come out with. So good morning to you. Thank you for your time.
Good morning.
We saw the screaming headlines. You're going door to door. Are you really going door to door?
Yes, we are.
Wow. Why is that?
Okay, so Ghana has joined, Ghana is implementing the global UN AIDS fast track target 90-90-90. And I'm sure viewers would like to know what the 90-90-90 is all about.
Definitely.
So the first 90 basically means that by the year 2020, we want 90% of people living with HIV to know their HIV status.
Okay.
And then the second 90 means that we want people who know their 90% of people who know their HIV status or who have been diagnosed with the infection to be put on sustained antiretroviral treatment. And then the third 90 means that by the year 2020, we expect that those who know their HIV status and are put on antiretroviral treatment will have their viral load suppressed. Okay. And so this is a short-term measure that if Ghana is able to do that, then we can be sure that we will be able to end AIDS by the year 2030.
What's the percentage of people who know their HIV status?
According to the Demographic Health Survey 2014, 43% of women between the ages of 15 to 49 years know of their HIV status.
Okay.
And then men is less, 23%, which is very, very low. And so it means that for us to reach that target of identifying 90% of people living with HIV and making sure that they are enrolled onto treatment and having their viral load suppressed is a huge task. And it means that we have to do business not as usual. We have to do something beyond the usual thing we have been doing. And so basically testing was kind of limited to hospital facilities. It is when you go to the hospital that maybe a doctor or a health worker can recommend that you take a test, maybe due to your condition.
Yeah.
And so we
decided
I think
to a larger extent, pregnant women, because it's one of the requirements.
Exactly. You go for ANC or antenatal care and you'll be encouraged or counseled to do that. So for us to achieve this target, because the figure I gave you clearly shows that testing rate is very, very low. And for the first 90, how would people know that they are HIV positive? You can't look at anybody's face and say, please, you are positive. It means that they have to be put we have to provide testing services. And so this is the reason why the Eastern region decided that we would do something different.
Okay.
So we started with outreach programs and basically using location and event-based approach. Location, event-based. So location means where there are actions, okay? Locations where people are gathered. We also go with our HIV testing services.
Okay.
And then we decided that, you go to a place where you expect to see a very big number, for instance, Derbes, only to find out that the numbers are not there. So we decided that if the numbers are not there, you already have sent your service providers to the field. You will motivate them anyway. Do you dispatch them to go home? No.
Okay.
So that is where we decided that, and of course, when you talk about HIV, people are a bit, they have a whole lot of things running through their head. And you know that nobody gets up one fine morning and say, Charlie, today I'll go to the hospital to know my HIV status. No. So we decided to do this door-to-door thing, or house-based HIV testing services. So you'll be in the house, we will knock, and then we will introduce ourselves. Normally it's one nurse and then a peer educator.
Okay.
So we talk to you about why we are in your house. We encourage you, talk to you about the benefit of knowing your HIV status. And for testing, we are interested in confidentiality and privacy as well. So we look at the house, and we look at where we can put our table and our chair down, and we start our business.
Okay.
And I have to tell you this, that there are homes that we enter, or compound houses, and we have almost everybody. All you need is for one person to say our test.
Then everybody just jumps on board.
The spirit will catch everybody. So it is.
So when exactly did you begin this?
2016. In fact, in 2016, we went for Odra, and we were expecting a very big crowd because Odra is noted for that. Only to get there, and we were told that they were mourning their paramount chief.
Okay.
And then their queen mother as well. And so there was some kind of ban on noise making. So everybody was like indoors celebrating. So where would you get them outside to provide them with HIV testing and to talk to them about, HIV? And so we didn't have an option. And that is where we actually started our door-to-door.
That was the trigger for the door-to-door.
And we realized that it was massive. So we replicated this in other districts as well.
How many homes do you think you visited so far?
We have visited so many, because for Ekropon, Edukrom, and Latte, and all those areas, we got more than 4,000 people testing. So we have really covered a lot of
And
things.
out of this number that tested, what's the number that came out, positive or negative?
Oh, the positives were not really quite many for that place. And for HIV, we also have our location in high burdened areas. And so we got around 30 people.
Okay.
Being positive.
But we're told that the Eastern region is a trouble spot. I mean, it's one of the places that give you headache in terms of HIV and AIDS.
Well, maybe it is changing, and maybe our efforts are also paying a lot of dividend to us. But it's an open secret that when it comes to issues about HIV prevalence, Eastern region, over the years, more than 20 years, we had always been the first. But for the past 2 years, we are actually seeing a nosedive of, a decline of our prevalence.
And to some extent, you can attribute that to the kind of strategy that you adopted.
Yes, because it's more comprehensive what we are doing. This one, it's getting many people to test. But the good thing is that when you test and you are positive, we also have to ensure that you are enrolled into care, so that at least your life can be prolonged.
Okay, so what has happened to these 30 at least?
Which?
The 30 that you found that they had the virus.
Okay, plus other, this one is only one district. And so we have done a lot in other districts as well. And so all those who are positive, we follow them up. In fact, on the field, it's more of reactive. The first test, we'll make sure we confirm and be sure that indeed, if we are giving you a positive test results, you are positive. And so after that,
how long does it take?
Oh, the test takes maximum 10 minutes, 5 minutes.
And the confirmation?
It's also like this.
Okay.
5 minutes, you are done. So if we put together, it's like 20 minutes, 15, 20 minutes, you have your results.
And how did the people take it? I've done a test, I think, twice. And the way you start going about it at the beginning, I mean, the person is almost thinking, Charlie, I have it. Because you're psyching the person, even though you don't know the outcome of the thing.
Exactly.
You're telling me about what you should do.
Exactly.
You know, why do you start like that?
Yes,
anybody would faint.
We need to do risk assessment. We need to prepare your mind. That is what we normally refer to as pre-test counseling. You know, if your mind is not prepared and it comes out that you are positive, what happens to you? Some of them, you cannot stabilize them. But if you do a very good pre-test counseling, you have already prepared the person's mind. You have told the person that you are either positive or negative. And so, and
but
of
sometimes
course,
you have the results, you know the results, but you start off the way that you
do. Yes, it is part of the preparation. It's part of the preparation. And so we do that just to prepare you to accept your results.
Okay, so I wonder what the new people took it.
Yes, they took it because we did a lot of, the counseling went well. In fact, there are outreach programs that we have embarked on, and people test positive and they actually thank you. Yes, why? Because maybe it started with something like a fever, and it was on and off. Then after some time, you had other skin condition, you started coughing, you have started doing this and that. You went to the hospital, they said malaria, you did malaria test, nothing, you did typhoid, they recommended other things and nothing. So it's like a year or more, it has been back and forth. And especially when you get somebody also saying, then this could be spiritual. So then you change your focus to spiritual issues and you start, you know, addressing it from that angle. And so there are people we meet, they have sold what they have just to take care of themselves, and they have never thought about taking HIV test. So for such a person, if you talk to him or her and then they take the test, after that, if they are positive, they say, thank you very much. I have just moved around hospital this year, this, that, pay this money to this prayer camp, whatever, and at the end of the day. So it is not, things are changing. First, when we talk about HIV test, say, hey, for me.
Yeah.
But now, even our Kwewu Easter, the recent Kwewu Easter that we had our programs.
You did voluntary testing there?
Yes, we got 9,648 people testing for 3 days. What were we doing?
What was the outcome of that?
Mobile testing. Yes, big time. Only 3 days.
What was the outcome of that? Did you find new cases from
there?
We
found new cases. And there are others that they knew of their status, but they came to test to find out whether indeed...
if anything had changed.
Exactly. But those people, we don't even add them to our data. And if for 3 days, you can get 9,600 plus
That's
testing,
massive.
That is massive.
Yeah.
And it tells you that it cannot be business as usual if you want something.
But the new cases you found there, can you put a number to it?
Well, we got less than 100.
Less than 100?
Actually, yeah.
Okay. But that's a good thing then, because I mean, the numbers that go there are in, even you said 9,000, you got 9,000 people voluntarily coming forward to test.
The other good thing is that, you know, people don't go there with a mindset to go for screening. They go there to enjoy. And so you wake up one fine morning, maybe your BS and other things are ready, and somebody is knocking at your door, talking to you about your health. And we train our peer educators to do that, and we also go with other materials on HIV, why you need to know your status, why this and that. So it's quite massive, and it's an innovation because people take advantage of their celebration to also know their HIV status.
But this must also be costing the commission some good money.
Sure.
So I wonder how you're funding this.
Yes. I am in the Eastern region, and so I normally write, I would send a concept note about what I want to do, and I send it to my headquarters, and they also look at it and support. But I must be quick to add that funding is a challenge. But for Eastern, you know, you can trust us. We are doing many things. We don't only want to rely on the commission because we know that funding is becoming a challenge. So we look elsewhere, we talk to people, we talk to some NGOs to also support.
So you raise
us.
funds internally. You have that kind of independence.
Yes, we are. But because as a technical coordinator, that is one of my roles, that I should solicit for funds. And so I have some partners in the US. They support me also to do testing in schools and persons with disability, people with a visual impairment, hearing impairment, and all those things. We have some intervention.
Good to know.
For them.
One of the, you know, on 8th day every year, one of the talking points for continuously for a good number of years had been antiretroviral drugs. Is it still difficult to get?
No. With the 90, if we run out of antiretroviral drugs, we'll be hot. Remember, I indicated that the second 90 means that those who are infected with HIV, they must be put on sustained treatment. Sustain is the emphasis, because you cannot start antiretroviral and go on drug holidays. No, you can't. And if you do that, you have complications, some resistance. So we're trying as much as possible, even to give those who are very stable, and we can attest to the fact that they are very committed. We even give them 6 months dosage, so that they don't, you know, we don't want to see them coming to the clinic that often.
Does it cost?
Yes, it costs.
So to the individual, do you have to pay for your antiretroviral?
No.
Okay. How about the testing, the door to door?
Door to door is free. Let me also add something. We do night testing as well.
Night testing.
So for instance, if multimedia, you are organizing a program which will eat into the night, I will also get my team somewhere. Locate a very nice place. We can have a confidential dialogue. And
so you just missed one of such events then, because we had the Y2K at the Silver Star Tower. So events like that, you could just come and set up somewhere, and then you do your voluntary testing.
And we can sit there up to 2 a.m., 3 a.m.
Really? So what's the motivation for you and your team?
Well, something like their TNT. Transport refund. That is what I give them, because, and you need people who are motivated themselves to do that.
Beyond the money.
Yeah, because if you have to look for, if you have to look at the money, you'll be discouraged, because we don't have that much. We don't have that much. But I have a team of health workers I have worked with over the years, and so they also have the passion for the work. It is when you travel to other places that you see feet dragging, because mostly when we travel to other districts, we don't want to move nurses or health workers from the regional capital, because when you have positive cases and you have other health workers from other, coming from other districts, following up, it becomes an issue. So for instance, in Kwewu, we have most of the health workers coming from the same place, so that if there is any positive or there is any issue for follow-up, you can easily follow up. And so sometimes we need to talk to the service providers, prepare their mind, and then we don't really force them, but I know there are some who are.
So if you're and I also understand that you're quite upset with some of the descriptions that we give to persons with HIV. So what's the right thing for me to say?
Okay, I'm not really upset, but sometimes it's so discouraging to hear. For instance, if you're a person living with HIV and you hear people describing you as Baba Sokramai, and all kinds of terms. And so people say HIV victims, HIV carriers. What are they carrying? HIV sufferers and stuff like that. I think that the right word to use is just a person living with HIV. They are not victims, they are not sufferers, they are not carriers.
But we also know that it's a virus. So can't you say, if you say a carrier, is the person not carrying the virus?
No. The appropriate way, every industry and the appropriate word you use, and your language should,
So how do you say that in Tree? Because I see that most of your issues has been the
really
local stations.
Exactly.
So what's
they can run
how should they describe that in
Obia when you're HIV.
Oh, okay, just that.
Well, yes, and in English, a person living with HIV.
Okay.
But when you are speaking a tree, and sometimes they want to describe them, that is how they say, oh, and Baba Sokramai when you're HIV, Baba Sokramai, and you know, like you will die, but you will not die. If you get HIV, it doesn't mean that you will die. And some of these description, they are, I mean, it discourages people from taking a test, because if I have to take a test and I hear in the morning somebody saying, "Na yare could be a war for no," and I'm, you know, those things, then it's like, wow,
that's like a death sentence.
If I take a test, it means that people will see me as having Baba Sokramai. But HIV is not like Baba Sokramai. It is a chronic condition which is manageable. Like somebody is managing TB, or somebody is managing hypertension or diabetes. Yeah. It's a chronic condition. So why do you describe me as having Baba Sokramai and then stuff like that? We also hear people saying, and the fight against HIV, and we need to combat it, and it's a battle. No,
it's not a fight.
It's not a fight. It's a response. We are responding to HIV epidemic. Okay. And people also say, oh, and the prevalence rate, and the rate is also part of the prevalence. So when you say HIV prevalence, that's it.
Okay, now that you've said that, what's the prevalence, just before we wrap up?
2.6% in Eastern region. What it simply means is that when you take 1,000 people at random, 26 will be positive. Okay. So that is what it means. But even though years ago we used to be 7.9, if we are at 2.6, it means that a lot of work has gone into what we are doing. Yeah. But our goal is to have a country, or to have Ghana, where there is no HIV and AIDS. Yeah. So it means that we need to do...
We still have a lot more work to do.
Yes. Nice. But I want to talk about the fact that we want to end AIDS by 2030.
2030.
We are ending AIDS. What does it mean?
That's like in 12 years.
Yes. What does it mean to say we are ending AIDS? Does it mean that all those who are HIV positive are going to be killed? No, that is not it. But we want a situation where HIV will not be, or AIDS will not be, a public health threat to us. And so we want to keep our persons living with HIV strong and healthy, so that they don't progress or advance to the AIDS age. Okay. And it means that everybody would have to take a test to know your HIV status. And if you are positive, we can enroll you into care and make sure that you are monitored and you are sustained in treatment and care. Okay. So that by the year 2030, we can really...
How often should one take the tests? If you've done it before?
You can take it after 6 months.
After 6 months?
Yes. And especially depending on your lifestyle as well.
Okay. Just before we wrap up, NHIS, is the antiretroviral covered under the NHIS?
Yes. And Ghana AIDS Commission had an intervention with the help of the Global Fund. And so we were registering all our clients, persons living with HIV, free of charge. We register you, and once you are a valid card bearer, treatment is free. Okay. So testing is free, treatment is free if you are enrolled onto
all right. Okay, so I want to say thank you, but I've got a curious question. Do you know how old a person living with HIV in the Eastern region lived for?
I have a client, she was diagnosed in 89.
Oh, wow.
She is still strong and healthy. She gave birth to 5 children. She lost 3 of them because those times it was not easy to take a test. It's not like now that we can knock at your door and present you with services. So even with that, she had to travel to Kolebu, and that was after she lost 3 of her children. 2 survived.
Okay.
She's still alive.
They've got the virus?
Yes, they are
the
HIV.
Children?
Yes, they are HIV positive. One is in the 2 are actually in the. They are all in the tertiary institution.
Oh, amazing! But they know.
They know they are positive. In fact, one of them, when I have a program for adolescents, she goes with me and she testified to them.
Oh, and she shows her face.
Yes,
she talks about
that she was not fortunate. She was born with it, and then she encourages students to take good care of themselves.
Amazing.
So she's there. She's one of our models of hope. And models of hope are persons living with HIV who have been trained to be peer counselors. And so we attach them to our antiretroviral site, and they assist health workers to provide treatment and services to their colleagues or friends or peers who are also HIV positive.
Interesting.
So she is at Regional Hospital Koforidua.
Nice. We should have you again in the studio. So we'll see how the feedback goes. We'll have you again, and then we can encourage people to phone in and speak to you. I think you're an amazing person, and you enjoy the work that you do.
Sure.
And you know, you are the kind of people that we need to be manning some of our institutions and doing the kind of work that you're doing. So thank you so much for your time.
Thank you
here
for
on the show.
having me.
Thank you.